Hey there, welcome back to the Func Med Nation podcast. I'm Dr. Steve Noseworthy, your host. Today I have the pleasure of interviewing Dr. Aristo Vojdani, and I'll get to his bio here in a second, but I'm recording this introduction actually after the fact. We've already completed our interview. And as usually happens whenever I have a conversation with Dr. Vojdani, it quickly devolves into questions about clinical applications of immunology. We do spend some time talking about his amazing history and his background and his insights into the clinical world of research in the immune system. But let me go through his bio here, and then we'll get to the interview right at hand. So Aristo Vojdani obtained his master's and PhD in microbiology and clinical immunology from Bar Ilan University in Israel, with postdoctoral studies in comparative immunology at UCLA and tumor immunology at Charles Drew UCLA School of Medicine and Science. He's a clinical professor at Loma Linda University in California and an adjunct professor at the Lincoln College of Professional, Graduate, and Continuing Education at the National University of Health Sciences. His ongoing research focuses on the role of environmental triggers in complex disease, and he has developed more than 300 antibody assays for the detection of autoimmune disorders and other diseases. He has 17 U.S. patents, over 200 articles, and 2 books, Neuroimmunity in the Brain-Gut Connection and Food-Associated Autoimmunities When Food Breaks Your Immune System, to his name. He is the CEO of Immunosciences Lab in Los Angeles, California, the chief scientific advisor for Cyrex Labs in Phoenix, Arizona, and sits on the editorial board of 5 scientific journals. This guy's the real deal. His many awards include the Herbert Wrinkle Award from the American Academy of Environmental Medicine, the Linus Pauling PhD Award from the American College for Advancement in Medicine, and the Personalized Lifestyle Medicine Institute Lifetime Achievement Award. It is my distinct honor and pleasure to have you listen in on the conversation we just had. Welcome, everybody. I'm so happy and thrilled and honored and privileged to have Dr. Aristo Vojdani with us today on the Func Med Nation podcast. Ari, thanks for taking time out. I know you're a busy guy. You sometimes travel all over the world with speaking engagements and whatever other shenanigans you get into.
Thank you so much, Steve, for having me on your program.
Well, I truly appreciate it. So I would imagine that there's a lot of people in the functional medicine community who know who you are at this point. But just in case somebody's listening or watching, why don't you just talk a little bit about who you are, your background, but particularly if you wouldn't mind sharing the story. And I've heard this story before, which is why I wanted to go through it, because I think it's powerful and compelling. But I want to hear a little bit about the story about how you decided or why you decided to go into the field of research, particularly with immunology. So you can start wherever you want and end wherever you want.
We are going back to 1967, when I took my first course in immunology. We had a teacher who came from Pasteur Institute from France to Israel to the university which I was studying, Bar Ilan University. And he, in the first lesson, he told us that the future of medicine is immunology. Again, I'm talking now about 1966.
Wow.
So after taking that course, the next year, 1967, we had advanced course in immunology. And I became very interested in the practical aspect of that course, mainly the laboratory component of that.
Right.
At the end of the course, the professor asked one question. That was the final exam. Explain what is immune surveillance. In 2 pages.
This is the 1960s.
Yes.
Wow.
Yes. What is immune surveillance? So I wrote that the body is immune surveillance is like a police department. It's like the army. each, there's, different parts, and each part, they have different responsibility. And so I went on and on and on talking about, then we knew about lymphocytes, a little bit about T and B cells. That's all. So I explained all of that, macrophages, T cells and B cells and all of that, how all together they protect us against the invasion. 2 weeks later, the professor came and with the results, the exam results. He said, Aristo, you scored 100%. And, being not native in Israel, I had difficulties in language barrier and all of that. I was getting C's, B's, but I never got A plus 100%. So then at the end of that course, the professor invited me to work during the summer in his laboratory. And it was in that laboratory, which in the first 3 months, he taught me everything he knew in the laboratory immunology. And the more I learned, the more I loved the field. And I ended up to stay in the same laboratory, not only finishing my bachelor degree, 2 years of master degree, and 5 years my PhD in the same laboratory.
In the same
I owe everything to that professor.
Yeah. Now, is that pretty unusual to stay in the same lab from beginning to end?
Highly unusual, yes.
And
yes,
was it just because of the relationship that you guys had formed, or was it because you thought he had particular insights into immunology? I mean, it sounds like he was very forward thinking for the 1960s, because, and correct me if I'm wrong, we didn't even discover like Th1, Th2 subsets, regulatory T cells until the 80s and 90s, if I remember correctly.
Yes. He was one of the pioneers in the field of immunology, and amazingly that he was working also in the field of comparative immunology, and his animal model was fish. But I was, because, Steve, fish is the first animal kingdom that they make antibodies. Starts from shark, actually.
Really?
Yes. And so it goes from, fish, and then amphibians, reptiles, birds, and human. And the curve goes like that as far as classes of antibodies. So he was one of the pioneers, and I was really lucky to spend time in his laboratory and learn, all that experience that he had. He transferred it to me. Whatever he learned at Pasteur Institute, he transferred that to me. And also I had the privilege of running and teaching the practical classes of immunology during 5 years of my PhD.
Yeah.
So that entailed, it's not like today that we want to do certain experiments, you have a list, you call the companies, and you order your reagents. No, I had to prepare reagents myself. I had to take rabbits, I had to take sheep, I had to take goats, inject them with an antigen, make antibodies, and then test antigen-antibody reaction and teach students with that. And so that's why it made me a unique person. And I appreciate,
I love that story, because I would imagine that a lot of people in our field who do know who you are probably associate you most strongly with Cyrex Labs, probably most recently, and your own lab, Immunosciences. Probably have no idea the depth and the breadth of your experience, and how much Like, I can't imagine the changes that you've seen in the field of immunology. How much more complex? I mean, you would think that as you learn more about a field of study, it becomes more simple. But what I've learned in my own studies is that the more I know, the less I understand to a certain extent. Or quite often I'll say, like, the more I know, the dumber I feel. And so how has your perspective on immunology changed from those early years in the 1960s and understanding that big concept of immune surveillance? How has that changed up until here we are at the end of 2022? Like, what's different for you?
It became definitely more complicated, but also the knowledge is helping us to use that for prevention and treatment of many, many disorders. Let me give you an example. In 1982, exactly, I remember, when I was working at UCLA, there was a special meeting in Carmel in California.
Mm-hmm.
And then there was many talks, and one of the talks was about the first cytokine, interleukin 1. And Stephen Gillis then started a company that was selling stocks for like $1, and 10 years later, if you would have bought 10 shares of those for $10, you would have been millionaire. So anyway, to make the story short, that was the beginning of the cytokines. Mm-hmm. And today, you know, Steve, that anti-TNF alpha is used for in the field of arthritis. Almost every single antibody, especially monoclonal antibodies, that by itself, which was discovered in the 80s, was huge progress in the field of medicine. That there is no field that today we are not using monoclonal antibodies against these cytokines, against that cytokines, including IL-17 and many others.
Right.
Whether it is arthritis, lupus, or multiple sclerosis.
Mm. Would you say that, and I think I know what your answer is going to be, but I have to ask anyways, like, would you say that there's a gap between what you and your colleagues know and understand about immunology and how that information is being applied in clinical practice, whether we're talking about conventional medicine or some field of natural medicine like functional medicine?
There is a huge gap. In fact, the gap could be recognized by the fact that today, really, we do not have physicians specializing in immunology.
Right.
Today, if you have a patient with immune disorders, either you have to go to allergists, they call themselves allergists and immunologists, which really they're not immunologists, they're allergists. They can desensitize individuals against certain allergens.
Yeah.
But other than that, they really do not understand complexity of the immune system. The second specialty, they send you to a rheumatologist. Unfortunately, rheumatologists do not understand immunology. So there is a need for practitioners to be specializing in real immunology. And that's why the field of functional medicine, personalized medicine, is trying to fill that gap. But honestly, I sincerely believe that we need to have young physicians to be able to go to specialty of clinical immunology and to be specialized in that field in order to be able to help many patients in need. Yeah. I see how much my own son, Elroy, who is practicing functional medicine, is busy. So he has to turn down so many patients in Los Angeles area. They call every day and they have to wait for 6 months to see a patient, to see a doctor.
Yeah.
You know, there is a huge need for many more physicians to be specialized in the field of clinical immunology and not allergy and immunology and not rheumatology.
Yeah, and I like how you make that distinction, clinical immunology. And I would imagine, like, as I think through that as a problem to solve, there's two dimensions. One is, and it doesn't really matter whether you're educated in allopathic medicine or, in my case, chiropractic, and all of my functional medicine training came later, or if your background is, say, Oriental medicine or something similar. I don't think any of us are trained in even good clinical immunology. I mean, sure, when I was in school, we learned about a white blood cell and a differential, but we certainly didn't learn clinical applications. So I think education is one problem. The other problem, and this is where I love that other part of your background, which is where you said you wanted to get into the laboratory side. Up until probably the last 5 to 7 years, I think from as a clinician, there has been a relative paucity of tests that were available to us to give us insight into things that we were speculating about. And that's all we could do was speculate, because we didn't have any hard data to prove us right or prove us wrong about, for example, is someone Th1 polarized or Th2 polarized? What's their natural killer cell count, for example? And so talk to me a little bit about, after you finished your PhD, how long was it before then until you started Immunosciences? And then eventually what led up to your involvement with Cyrex Labs?
Yes, first of all, I came to the US in 1979, went to UCLA, did my postdoctoral study, and then went to Harvard UCLA, then Charles Dree UCLA School of Medicine and Science, where I did study in the field of tumor immunology, where I learned more about natural killer cells. By then, we knew about T cell, and then we knew about natural killer cells, how to do testing for NK cytotoxic activity. Then about 1986, I decided to leave the academia, not entirely, but not to get salary from the academia. I kept my ties with the university, and then went to a biotechnology company where I developed the first food IgG testing by ELISA. Many people do not know that. And I do take credit for that. However, because of the way the test was done in many laboratories, for more than 25 years, I stayed away from that completely. But about 5 years ago, I decided to come back and not only to write my book, and also develop a real test, the most reliable test for measuring antibodies against food, whether it's IgG or IgM or even IgE. One of the major claims or findings that I had was, if we eat certain food cooked, why the allergies are testing with skin against raw food.
Yeah, right.
That's why they get false negative or false positive.
Yeah.
So in 2008, I published this article in one of the major journals, measuring antibodies against raw versus cooked food. And that was the idea about developing Array 10 for Cyrex laboratories.
Right.
And unfortunately, Steve, in the field of functional medicine and the laboratories who are practicing, practitioners really do not know who is good, who is bad.
Yeah, and that's one of the questions that I wanted to ask you about, because I know about certain good labs because I learned about good labs from other docs who knew about good labs. But let's say somebody's getting into the field of functional medicine and they really don't know much about the different labs that are out there or their reputations. How does a new practitioner distinguish a good lab from a bad lab? I mean, what are the metrics that we in the trenches should be looking for? Is it just simply the lab is CLIA certified? Is that enough? Or is there more that we need to look for?
That's not enough. If the laboratory is CLIA certified, if the laboratory is CAP certified, College of American Pathologists, Immunosciences lab is College of American Pathologists certified, and I do take a lot of pride into that. But that is not enough. That means that when you were asked few questions by the inspector, you could answer them and you passed. That's all. But no one knows that when you started developing a test, first, what kind of raw material did you use? I gave you example of cooked versus raw food.
Right.
That was one example. Second is how pure the antigen that you use. How pure was that? Thirdly, even if it was pure, did you standardize it? Standardization of assay is extremely, extremely important. And then finally, did you go through all the steps necessary to validate an assay? I have a binder of this size for array 10. It took us 3 years to do validation for 180 foods. Then, Steve, my question is, how come there are one laboratory mainly who has a reputation that goes around, looks at other laboratories, goes online or whatever, goes to different meetings, pick up their literature, and then 3 months later, they come out with the same test, which I did spend 3 years of my life.
Right.
So unfortunately, practitioners do not know the difference between good versus bad. But I would like to throw in here something like this, that these days, you know, it's a holidays. We are going to buy presents for our children, grandchildren in my case, and you can go and see the same sweater or you know, for $20 or $30 if it's made in, for example, China.
Right.
But if it's made in Italy, you have to pay $160.
Yeah.
So when really a laboratory comes and say, our prices are much cheaper than the other laboratory like Cyrex, ask yourself why they're offering their test so cheap. And you know, I'm not sure, let me add this, and then that laboratory gets money up front from the patients first, some amount, and then turns around and also build their insurance. Which
they're double dipping.
Never will do that.
Yeah.
At the Immunosciences lab, and will never do that at Cyrex Laboratories. Please go ahead.
Yeah. So the whole idea of having several different standards that have to be met to be considered like an accurate, reliable, repeatable, reproducible test. Are these questions that we as practitioners should be able to call up a lab company and talk to a sales rep or maybe one of the executives and just, I mean, do you think that they're going to be honest to you and or with us and say, you know, oh, we only took 3 months to standardize this test? Or do you think that they will try to skirt around the question? And is that a sign to me that someone's not being entirely honest? I hate to say that, but I mean, if someone's got a testing methodology that either they didn't go through the due diligence of standardization and validation, or if they use an inferior technology and they try to spin it in all of their promotional material to make that technology, which is inferior to other things, seem as if they are as good. I mean, are these things that we can expect these labs to be honest about?
I don't think so. They're going to be honest with you. No.
Yeah.
Everybody today is saying, I am the best. I am the best.
Right.
And not only I'm giving you the best, my prices are cheaper than other laboratories.
Yeah,
and
so there's always a reason for that, is what you're saying.
Please ask if there is a reason behind why a laboratory offers a cheap test. And let me give you an example that one of the pillars of quality of Cyrex is doing testing in duplicates.
Yes. Yeah.
Meaning you use twice more antigens, twice more other reagents, twice more personnel, and so therefore the test is going to become more expensive. Okay. The methodology also today, ELISA, I talked about 1986 that I developed ELISA for IgG.
Right.
Still is the gold standard.
Right.
No test could come close to the quality of ELISA. And
is that true, Ari? Is ELISA the gold standard not just for food antigen antibody relationships? Is that true for autoimmune testing as well, for example, or leaky gut testing?
For every single test right now, we have more than 20,000 approved kits in the world who are using ELISA methodology. And that's why, for example, if there is a laboratory who is using microarray, still they have to compare their microarray to ELISA. And since I'm mentioning that, let me give you some kind of analogy. In the case of ELISA, if you play golf and you go to the golf course and you play golf, right? So it's a large, huge field, but playing the other test, microarray, is like mini golf. They are using 1,000 amount less reagents. And so you just compare these two. Can you send someone who is the best in playing golf, send to play mini golf? So obviously, when you cut in the amount of reagents, no matter how the method is good, the method is going to suffer from sensitivity, specificity, and reliability. And so therefore, we are proud that at Cyrex Laboratory, we are not cutting any reagents. We are using the most pure reagents, biochemically identifiable antigens. We standardize them. We do them in duplicates, and then that's why we are standing behind the quality of testing that Cyrex is doing. And my hope is one day the practitioners will realize the importance of quality and the quality of testing that Cyrex is providing, and hopefully they will be able to differentiate between good versus bad.
I'm not aware of any other lab that even claims to do like double run testing and quality assurance. Are you guys the only one that you know of that does that?
As far as yes, I believe we are the only one. Yes.
And when I say you, we're referring to Cyrex Labs. Do you do the same thing with your testing at Immunosciences?
I do for in-house developed assays.
Okay.
For example, my Lyme disease test, which has 26 different components, everything is done in duplicates.
Yeah.
My HHV6 test is done in duplicates. But if I do Epstein-Barr virus and I spend $400 to buy a kit, okay, and to offer that with certain price, I have to do that in a single one.
Sure. Yeah. I mean, yeah. And obviously, that's not many people would order.
That's fair to say that. Yes.
Yeah.
Yes. So many laboratories do not do in duplicates. No.
How often, when you do that double quality assurance approach, how often do you find that the test results are not coinciding. And what do you do at that point? Do you run it a third time, or do you go back and say maybe there was something wrong with the sample, collection procedure, spoiled during transportation? I'm sure that you have measures in place to minimize those errors.
Yes, in 3 to 5% of the cases.
Wow, that's pretty low.
Yeah, it's pretty low.
Yeah.
But do you want to be that patient that you are negative for Lyme, and I'll report you as positive, and your doctor will put you on antibiotics for 5 to 10 years? Do you want to be that?
Yeah.
So even 3 to 5%, for me, it is very significant.
Yeah.
So yes.
So here's a question, like with all the things that you've done in your career, and I know you've authored a couple of books recently. You own 14 or 15 patents in the field of immunology testing. You own one lab. You're the chief science officer of Cyrex Labs. In your entire career, what are you most proud of? And maybe more importantly, what would you go back and change and do differently if you could?
The first thing that I developed was very, very proud of, that was testing for H. pylori. That also many people do not know, that I had NIH grant and developed IgG testing for H. pylori, and then we proved that IgG correlated with clinical disease of
I had no idea.
ulcers. And not IgM and not IgA. Imagine an organism in the gut, and the mucosal immune system should react and make IgA. We found IgG was more significant than IgA.
Are you talking about serum, or are you talking about stool?
Serum.
In serum.
Serum.
Wow.
Yeah.
I mean, I was under the understanding, and please correct me, that even post eradication, that serum antibody levels can stay elevated. So, how much stock can you put in a positive serum antibody test for H. pylori? I mean, and maybe I've had it wrong all these years.
Again, depends what antigen are you testing antibody against. Today, we know that specific strain of H. pylori makes an enzyme called urease. And the antibody should be measured against that specific antigen, and that antibody against that specific antigen correlated then with peptic ulcers.
Really? So if somebody orders labs from, Quest or LabCorp, any regional lab, and they're just ordering serum H. pylori antibodies, we don't know which antigen target the test is actually being run against.
We don't know in many laboratories, but I believe Quest and LabCorp, they're using that urease.
Okay, so that's good. Very well. That's nice to know, because that's completely changed as my clinical approach and the utility of serum testing. See, that one question and answer alone was worth the podcast.
So then, when I started the Immunosciences laboratory in 1989, and actually, other than specialty lab, we were the second immunology laboratory in the country, in the US. So I started offering flow cytometry. I started offering measuring antibodies against all kind of environmental factors,
right?
Toxic chemicals, food, pathogens, and their importance of pathogens in autoimmunity. I started all of that in 1989. So really, I cannot choose one out of so many things that I did.
Well, and it's
sciences lab, but really, when I put together Cyrex, I took the best of my activities during probably 30 or 40 years. Now I have 50, close to 60 years of experience in clinical immunology laboratories.
You don't look that old, man.
Yeah, but when I started putting testing for Cyrex laboratories, I really put my best together in order to offer testing for Cyrex laboratories. So the most important aspect of my work, if I will summarize it in a couple words, will be that the importance of detecting early events
Right.
in any disease, whether it is inflammatory, autoimmune, neurodegenerative disorders, we have to detect the early events. And Cyrex testing is helping practitioners to detect the early events responsible for induction of abnormalities. And we have to realize that for any disease, it is not like we go to bed, we wake up in the morning with a disease.
Yeah.
For every disease, in some cases takes months, in some cases takes years.
Right.
Example, autoimmune disease. If you take certain medication and that medication can destroy some of your cells and you make anti-nuclear antibodies, will take few days to 3 months to develop an autoimmune disease. But in other cases, may take 5 years, 12 years, and the longest I have heard also read in the literature, in some cases takes 18 years to develop an autoimmune disease. And so therefore, practitioners should look at early events. And by the way, the early event is really the message of functional medicine, the root cause of many disorders that we are dealing with.
Yes, and being proactive rather than reactive.
Yes.
Yeah.
Yes.
So are you talking, when you're talking about the earliest, let's look at Cyrex as array number 5, right? The multi-tissue antibody screening test. Are you talking about results that land in the equivocal range, or things that are frankly positive, but we can't see any evidence of clinical manifestation? Because you can see antibodies that are out of range, but they just simply haven't developed the disorder at that point. Is that what you're talking about in terms of forward thinking, being proactive, like it's a snapshot of what might happen or what is likely to happen if you can't figure out what your triggers are and then start to do things to control or eliminate those?
Let's just imagine right now an arrow.
Yep.
The first part is white, then yellow,
yep,
orange, red. So the white is we are completely healthy, no antibodies. But stage 1 autoimmunity is you make some antibodies and we detect them in array 5. That's a good example.
Right.
But there is no clinical symptomatology. That's an early event. We should pay attention to that.
Right.
Because that's where we can make a difference. In the orange, the patient is making antibodies, exhibiting some symptomatologies, but they are not damaging enough to cause some malfunctionality.
Right.
Also is important to detect both the symptomatology and well as the early events, because again, at this stage, you can make some difference. But when we go to the red, which is the antibody, by the way, the antibody may disappear because when the tissue is damaged completely, we may not have enough antigen to make.
Well, there's no target, right?
Yeah. The cells are attacking, the T cells, Th1 and Th17 are attacking the tissue, and huge disability you could see in that patient. That is too late, unfortunately.
Mm.
So therefore, the message of Cyrex is detect at stage 1 if it's possible. And if not at stage 2, but not at stage 3, which all the laboratories, other laboratories are trying to do. And most practitioners say nothing is wrong with you.
Yeah.
Unless you are in stage 3 of autoimmunity, they are not going to give you treatment.
Yeah.
Other than the field of functional medicine, which pay attention to this.
Right. Right. And I would venture to say that even if, just by the nature of what we as clinicians tend to do, changing someone's diet, improving their lifestyle, changing how their bodies interact with the environment. I mean, these things that we would naturally want to do anyways with someone who has some kind of autoimmune reactivity. So I would imagine that there are a lot of, this is one thing that I thought about functional medicine. It's one of the kind of the sad realities is that we probably don't know all the things that we prevent, right? We do things that are necessary to improve whole body metabolic integrity, let's say. And we don't know that we staved off neurological autoimmunity or changed the path of neurodegeneration or, averted some type of metabolic crisis somewhere down the road. And I guess that's a cool thing to say, but it's kind of sad that we don't know all the benefit of the things that we do. Let me spin the conversation around just a little bit, because we very quickly got into the clinical stuff, which I thought was probably going to happen. I think every single conversation you and I have had, no matter how it starts, it always ends up in the same place was, well, what about this? And what about that? I had a list of questions. I said to you before we started recording, I said, I think I could do an interview with you once a week for a year and still not run out of things to talk about. So I do hope at some point you'll come back on so we can have more conversations, maybe about specific things. I want, for today, this being our first interview, I wanted to stay relatively general and focus in on some of the things that are important, particularly for practitioners who are new to functional medicine. And so one of the things I wanted to ask you is, and I have my own opinion, but I'd like to hear from you. Like, how important is it for someone to have a fundamental understanding of immunology? And how much does a practitioner like me really need to know? Like, I'm obviously not going to invest the time that you did and spend all the years leading up to your PhD. But how much do I need to know as a practitioner?
I think the understanding fundamentals of immunology is going to help practitioners to put more focus on the early events and the role of exposomes in general. In many,
can you define the word exposome for anyone who's not familiar?
Lifetime lifetime exposure to external and internal. We
right.
forget about the internal factors. You may ask, what is internal factor? Let's say, let's talk about methylation. Some proteins become methylated. Why proteins become methylated? Citronylation. Yes, we measure anti-CCP antibodies, and it is detected in about 70% of patients with rheumatoid arthritis.
Right.
But why our proteins internally become citronylated? The same thing for celiac disease. Why gluten becomes deaminated? Gluten peptides become deaminated. And so therefore, like a lock on the key binds to transglutaminase, and then we make antibody against the combination.
Right.
So those are the internal factors. Of course, they are associated also with external factors.
Yes.
So therefore, that's why the definition of the exposome is the lifetime exposure to external and internal environmental factor is called exposome.
Right. So how, I'm sorry to interrupt. Go ahead, please.
Because there is another word called exosome. Exosome is something else. Exosome is some kind of particle on the cellular membrane and vesicles on the cells. That's exosome. With my accent, I don't want people to mix between exosome versus the exposome.
So how would you define the fundamentals? I mean, when you say we need to understand the fundamentals, you're just saying, hey, we need to run like a CBC with a differential, and we need to know some basic rules of how to identify acute infections or chronic, or use the differential to give us clues as to whether or not we're dealing with some kind of a bacteria or a virus, which, to be honest, I mean, I've used that clinically and I've taught it in seminars as well, but it seems to be very monolithic and very one-dimensional. And especially since you came out with the lymphocyte map with Cyrex, which to me is an absolute game changer. It's really opened my eyes to clinical realities where it's very easy to get fooled with superficial analysis and superficial understanding of very complicated systems. And I think in the world of functional medicine, whether an individual doctor kind of recognizes this or not, we're working with the neuroendocrine immune super system, right? And the way I look at it is those things are really simply just different facets of the same thing. And on some level, you can't have a sensible conversation about the immune system without also talking about how the immune system interfaces with the brain and the hormonal system. And can flip that around and look at it any direction that you want, but it's still the same thing. And so talk to me a little bit about what you mean by fundamentals of immunology and how much we need to know. But if you could touch at this, and I'll remind you, if we get lost on a bunny trail, like how is it that you can have a normal white blood cell count and a normal differential? Yet if you do a little deeper analysis, you see all kinds of immune dysregulation. Let's go there.
I worked with more than 5,000 clinicians, practitioners, MDs, DOs, chiropractors, MDs, and I have respect for all of them. And here I'm saying I love all of you. Okay, but please, some of you, when a patient is walking into your office for the first time, you are going for fishing expedition because you don't understand the fundamentals of the immune system. If a patient will walk, if I was the practitioner, which I'm not, okay, but I know my son is doing that, that look at the root cause of disorders. Majority of the root causes starts in the gut. I have thousands and thousands and thousands of articles that there is no single disease now that has no association with gut dysbiosis or gut abnormalities. So that's why it starts with array 2. Which is about leaky gut.
Yes. Yep.
Also, understanding fundamentals of the immunology, and we know that the immune system interacts with every component of the body, but particularly with the gut and the brain. That's why you remember the triangle on the cover of my book. You have the lymphocytes, you have the brain, and you have the gastrointestinal tract, and then connection between these three.
Sure.
So the second test, if you want really just to stop there, order the lymphocyte map. Today, I can attest to this, that the extension of lymphocyte map is one of the most important development of my life. And so, yes, CBC helps with only few dollars to detect many diseases.
Yes.
But since I did for 25 years, half lymphocyte subpopulation, all the way T cell, B cell, CD4, CD8, and their ratio, I found that CBC could be in many cases, completely normal. And then T and B cell and CD4, CD8 was abnormal.
Right.
Now, since we extended that to Th1, Th2, Th17, Treg, and 3 types of natural killer cells, I have seen many cases now that all the way to CD4, CD8. Everything is normal. Then you see a patient having twice more NK cell.
Yeah.
That has significant clinical meaning, Steve. It could be a virus, could be a cancer, could be other environmental factors. I have seen many, their Th17 and Th1 is elevated, but CD4, CD8 completely normal. That is very important because that shows the individual is not only Th1 dominant, the two autoreactive lymphocytes, Th1 and Th17, which are known to attack human tissue, including blood-brain barriers, opening the tight junctions, and now the lymphocytes get into the brain, causing neuroinflammation and neurodegeneration. So then finally, looking at regulatory T cells, cells that regulate the immune system. If you have high Th1, high Th17, low Tregs cells, that's a double whammy. That's, the individual will be in significant harm in the future if we'll not do anything about it. Fortunately, in the field, there are many, many publications. I'll just mention one. A fantastic article was published in one of the major journals about resveratrol. Resveratrol by itself. Of course, the study was done in mice. 20 milligram per kilogram body weight. Decreased Th17, decreased Th1, increased regulatory T cell. That is fantastic. And there are many, many hundreds of other remedies, including medications. For example, minocycline, doxycycline, even dexamethasone could do some of these. I'm not saying all of that, but some of them.
Yeah.
So not only we have now a method to detect early events in autoimmune and neurodegenerative disorders, inflammatory and many more, we have also an answer for them, what to do about it. And finally, I would like to say that many laboratories still are measuring cytokines and calling that Th1 cytokines and Th2 cytokines.
Right.
Let's take example of interferon gamma. Yes, it is produced by Th1 cells, correct. But it is not unique to Th1 cell. It is produced by natural killer cell. It is produced by red blood cells, Steve. It is.
Oh, I didn't know I didn't know the RBCs.
Platelets.
Yeah.
Whether they absorb them from the blood and then they release them, I don't know how the mechanism. I don't think they produce it.
Oh, I see. So they're just carriers, for lack of a better term.
But when you measure blood level of cytokines, you really don't know interferon gamma coming from Th1, coming from other type of cells.
Other types of cells. And I think that that's an example of how things have become more complex as we know and understand. So I would imagine that if I had asked you 15 years ago what the fundamentals of immunology are, you would have given me a slightly different answer, because we didn't have the discovery of Th1, Th2, Treg cells, Th17, and all of that stuff. One of the questions that I have, and this is a question I ask myself quite often when I get my own results for the lymphocyte map on some of the cases that I work on, and that is to understand how to differentiate between a lymphocyte map profile that is a desirable, healthy response compared to deciding that a profile is part of their pathophysiology needs to be corrected. Like how do we decide when their immune system is competent and doing what it should, and when it's not competent and it's dysregulated?
Yeah. First of all, you look at the test results. You don't want anything in the abnormal column.
Okay.
the red column. Now, in some cases, you may also argue with me that let's take CD4-CD8 ratio. Right now, the reference range at Cyrex is 1 to 4. Do I think 3.8 as a normal? I honestly know. Because if I look at my own CD4-CD8 ratio, which from 20 years ago, from 30 years ago, it used to be around 1.5, 1.6, 1.7. So the ideal CD4-CD8 ratio should not be higher than 2.0, meaning 2 CD4 cells, 1 CD8 cell.
Right.
But as we age, it seems that the number of CD4 cells, especially memory CD4 cells, goes higher and higher. And therefore, the ratio goes higher and higher. So that's why we have to interpret the results in the context of many other factors. One of them is age.
Mm-hmm.
The
Understood.
person that is that you are looking at his or her results, is she 60 years old or older than 60? Is she 70 or older? Is she 40 or 30?
Mm-hmm.
Makes a huge difference. But I really love to see CD4-CD8 ratio around 2.0 and not higher than that.
Right.
And
So
the same thing applies to the other values in there. I would like to see everything in the middle of that reference range.
So what you're saying, I'm trying to translate that into something practical that anyone listening can take away. You're saying that even low normal and high normal results could be an issue. They don't necessarily have to be outside of the reference range that you use, correct?
Yes, you should look into that also in the context of your patient's
right.
age and other demographics.
Right. So here's another example, and this is a case that I'll probably end up consulting with you on. I recently got some labs back. We did your Lyme B panel from Immunosciences, and he's got a multi-positive Lyme panel, including co-infections. Array 7 showed some neurological antibodies, and his lymphocyte map was relatively balanced. He did have a couple of findings, but I almost would have expected that when we had something like that we would see some increased activity with his natural killer cells or see some skewing of the Th1, Th2 systems. Didn't really see that in this particular case. And so this is one of the cases or circumstances where I'm trying to figure out, is this an okay balanced immune response, or does he have a chronic Lyme issue and probably a neuroborreliosis because he's not able to mount a more aggressive immune response?
I think.
So what would you say to that?
Yeah, we should not forget that the immune system simply is divided to two components: humoral, the cellular.
Right.
The humoral is mainly the antibodies, IgG, IgM, IgE, and the cellular start from, let's say, macrophages, T cells and B cells, all of those Th1, Th2, Th17, Treg that we talked about. So yes, it is possible to have abnormal cell-mediated immunity, normal humoral immunity, vice versa. The antibody could be completely abnormal and the lymphocyte map will be normal. And in some cases, you'll see combination of both as well.
Right. Understood. Boy, there's like a million other questions that I wanted. I'm trying to be respectful of your time. How much time do you have, by the way?
I have time. If
you have time. Okay. So that's amazing. One of the things I wanted to talk about was pathogen cross-reactivity in autoimmune diseases. And, you know, this is something that we see all the time. We talk about it all the time in the functional medicine seminars that I've been part of over the last 15 years or so. Can you just take a second, and you can do this very quickly, because I'm hoping that most people listening have a basic understanding of things like molecular mimicry, but can you just talk a little bit about cross-reactivity, what it is, why it's important? But I want to get to the question about, if I, as a practitioner, have someone with an autoimmunity, easiest one to pick on is Hashimoto's, or we could talk about neurological autoimmunity. If we were to develop a short list of viruses, for example, or other latent type infections, which ones should we focus on? And then I have a follow-up question that's a little bit more specific, but let's start with what is cross-reactivity in autoimmune disease? Why is it important? And what are the most usual suspects that we should be investigating in terms of the viruses, et cetera?
I highly recommend your viewers to read 2 articles that I published in the journal called Pathophysiology. The role of exposomes in autoimmunity. The first article is about toxic chemicals. Particularly, we put emphasis on aluminum, food coloring, and heavy metals. But that doesn't mean the others do not deserve similar attention. But those are just few examples. Food, we emphasize mainly gluten and dairy because recently an article was published in Proceeding National Academy of Science and summarized even in Scientific American how much casein contributes to multiple sclerosis. So that is the first issue. The second issue, or the second article, is about the role of pathogens in autoimmune diseases. And I started with oral pathogens. As you know, the history that's very close to my heart. My mother developed arthritis after having oral infection years later. And I did prove when I was a graduate student, I did prove that Porphyromonas gingivalis antibody was extremely high in her blood at that time. And therefore, then I connected the dots.
Yeah.
So now hundreds of articles are published in scientific journal. I did summarize that in that article, how much oral pathogens play a role in autoimmune disease, now particularly in neurodegenerative disorders, including Alzheimer's. And then I talked about herpes viruses. Herpes viruses, again, especially if I will choose 3 from those, well, first of all, HSV1 and 2, cytomegalovirus, Epstein-Barr virus, and the most important one is HHV6, human herpes type 6. All of these are being summarized in that article, how much through molecular mimicry and other mechanisms contribute to autoimmune diseases. And finally, I finished that with SARS-CoV-2 as the autoimmune virus. In fact, let me hold here, see if you can see this. This is, do you see it? No, okay.
Yeah, there it is. Yeah.
Okay. This is a chapter I wrote in a book by Schoenfeld. Let me see. Anyway, this is a chapter. The title of the book is Autoimmunity, COVID-19, Post-COVID-19 Syndrome, and COVID-19 Vaccination. Autoimmunity in association with all of that. So SARS-CoV-2 shares homology or epitope similarity, meaning several amino acids from one protein is almost identical to another protein from human tissue in this case. Thyroid, gut barrier proteins, joints, brain, and many more, which I published that in the journal called Frontiers in Immunology. So far, we had close to 200,000 individuals that reviewed that article which I published in 2020. In the follow-up article recently published in the same journal, Frontiers in Immunology, we showed actually molecular mimicry not always is bad. In this case, SARS-CoV-2 and diphtheria, like DTaP vaccine, cross-react with each other. So if you vaccinate yourself, Steve, with DTaP or Tdap for the adults, that will protect you against SARS-CoV-2 in the future.
Interesting.
Okay, so that is, the harm of molecular mimicry and also the benefits of molecular mimicry. We showed that several foods cross-reacted with SARS-CoV-2. But so back to the issue, yes, if you do research, right now you go online, that there is, first you do search and you find, you have a question and you do search. Let's say, again, you are interested in thyroid. In the case of thyroid, you will find many. But in something that we don't have at all information, you go online and search. And I'm sure you are going to find from 1 to 20 or 30 or 40 peptides that cross-react between that pathogen that you are looking for with different human tissues. Now, in the case of thyroid, we have the luxury, I have all these articles just with me, that studies has been done for many, many, many years. If I will summarize all these articles, you will find every single pathogen, which is an array 12.
Right.
To some degree cross-react either with thyroglobulin, with TPO, thyroid stimulating hormone receptor, with T3, with T4. Why thyroid so much is target of autoimmunity? Because it has all of these. So many antigens, so many factors. But if I will summarize, the most important 6 out of probably 30 that I know.
Yeah, that's a good list to have. Those
will be Yersinia enterocolitica. You know about that.
Yep.
Okay. Borrelia burgdorferi, Lyme disease. These two cross-react with each other also. You could have a patient with Yersinia enterocolitica in the gut, and you will get false positive results for Lyme.
Golden nugget right there, whoever's listening.
H. pylori. All of us, we may have H. pylori in our stomach.
And I see, listen, I do a lot of stool testing, and I find H. pylori probably in 70% of the stool samples we get back.
So why in some it's causing harm, including autoimmunity, including thyroid autoimmunity, but in the others, no. We don't have the answer. So that's number 3. Epstein-Barr virus. Please pay attention to that. HHV6. And finally, this is another golden nugget. Clostridium botulinum. Why that is so important, Steve? Because Botox is made from this bacteria.
Yeah.
And if you dare to tell my wife or your wife or I'm just joking, my wife doesn't use, but many of her friends are using.
It's not just women these days, right?
Tell them that you have thyroid autoimmunity, you should stop injecting yourself with Botox.
Yeah.
Then see what will be the reaction. But this is the mechanism.
Do you think that the proper clinical management of an autoimmune case includes an analysis of potential cross-reactors? I mean, should that be something that we do as routine analysis, or do you think we should be looking for some clinical clues that they may have a reactivated chronic infection and only then do that type of testing?
My answer will be that when I developed array 12 for Cyrex,
yeah,
I did not go against after H. pylori, the whole bacteria. I went after specific antigen of H. pylori that cross-react with human tissue. Give you another example. Enolase is an enzyme in human tissue. But enolase also is an enzyme produced by Candida albicans.
mm-hmm.
So we measure antibodies against Candida albicans enolase. Why that is important? Because enolase, if the patient makes antibodies against Candida enolase, that antibody can turn against the joints of the patient and also can turn against thyroid of the patient, because that's the issue of cross-reactivity exists between human enolase versus Candida albicans enolase, and there are other microorganisms contain enolase. Another one is human heat shock protein 60 is involved in cardiovascular and autoimmune diseases, and HSP60 shares homology with thyroglobulin, with thyroid peroxidase. And so therefore, when we make antibodies against chlamydia heat shock protein 60, which shares almost 70% homology with human heat shock protein, then those mimicry can contribute to cross-reactivity and autoimmunity. In this case, could be cardiovascular autoimmunity or thyroid autoimmunity. So really, you have to do the array 12. If the patient is making antibodies against any of these antigens, which are designed to be cross-reactive, then you should remove that, try to treat that organism, and hopefully will not release that component which cross-react with human tissue.
Right. So the, you said a little while ago that we don't know why some people experience cross-reactivity and others don't, even though they may have the same organism. And I have asked you this question before, and I wanted to ask it again because I want to be confident of the answer and how it affects how I think clinically. If you have somebody who does have an organism, let's just use an organism rather than food, for example, that has the potential to cross-react, will they also show elevated antibodies to the thing that they are cross-reacting to? So, for example, they have Epstein-Barr as an active issue, and they are cross-reacting. Will we see elevated thyroid antibodies, for example? Is that a guarantee, or is that it just depends on the person's immune system?
I think it depends on the person's immune system. That is the answer why some people get infected with the same organism. One develops autoimmunity through mimicry, the other ones do not. All depends on antigen presenting cells. As you know that if a virus or bacteria get into our body, the antigen presenting cells cannot take the whole virus or bacteria and present it to T cell. They have to break it down to smaller parts called antigens.
Right.
And then the antigens will be broken down to smaller peptides. The peptides then will be presented on major histocompatibility antigen, then goes to the B cells, and then we produce antibodies. So what are the chances in this particular case that a bacteria such as, let's take Clostridium botulinum, which I made, my case, which the toxin, the Botox, is only a small part of that. What are the chances that in all individuals, the antigen presenting cells will take only the Botox part, present it to B cells, and B cell will make antibody against them. I think that is not going to happen in every single person.
Right.
It depends on their genetic makeup and many other factors that we don't know even about.
So let me ask the question in a slightly different way. Is it possible for someone to be experiencing cross-reactivity without expressing antibodies to the human tissue part of that equation?
Yes.
And here's why I ask this, because I just did a consult with a lady, middle-aged lady last week, and she's seen other practitioners, and she gave me some Cyrex testing that's already been done. And her array 12 showed frankly positive Candida and Acinetobacter, but her array 5 was completely normal, yet her main complaint is severe burning and pain in her lower extremities, to the point where she's been in a wheelchair for a while because she can't stand. It's too painful. So for all intents and purposes, we don't see antibodies to myelin basic protein or xylogangliosides, yet she has the clinical picture of peripheral neurological autoimmunity.
With that introduction, I know for you, then you have deep understanding that Acinetobacter is involved in neuroimmune disorders.
Yes.
Yeah.
Yeah. And so I'm thinking that she falls into this bucket because, I've always, as an educator, I've always found it very challenging to teach nuances in a 3-hour seminar, or even in a 3-day seminar where only a portion of it is dedicated to the immune system. You can teach broad strokes, but you can't teach the depth and the detail and the nuance that really makes a difference, particularly in complicated cases. And, maybe someday that will change from the educational standpoint. So, my thought process with this particular case is that I am dealing with a neurological autoimmunity. I can't prove it. I mean, I'm not going to diagnose her with that condition, but I have to proceed clinically as if that's what the issue is. And so the other question I have is that if you have a situation, I mean, it's easy if you have, for example, a food cross-reactivity, you just stop eating the food, and that should make a really big difference, other things being equal. But in a circumstance where you have a latent infection, you have something that you're never really going to get rid of, all you can do is, as I say to my clients, beat it into submission and learn how to control it so that you're in charge rather than it being in charge. So in cases, for example, with the Acinetobacter, assuming that that's the issue, can we get rid of that? Is that really what the goal is? Is the goal to protect the target tissue that's being attacked as a result of the cross-reactivity? Or is the clinical focus more on resolving the infection? And I don't have a lymphocyte map, so I don't know what her profile is. But is the focus on the trigger part, the offending part of the cross-reactivity, like get rid of the infection, control the infection? Is that really what the primary goal is from a clinical perspective, or should be?
I think there are two goals in here. If possible, to control or get rid of the pathogens, if possible. If not, to strengthen the immune system, and the immune system hopefully will take care of that. In the case of Acinetobacter, I will protect the blood-brain barriers.
Yeah, and interesting.
And resveratrol, by the way, it's also repairing the blood-brain barriers. I know that patients with ALS using a lot of resveratrol, walking, exercise can repair the blood-brain barriers. Something is so cheap and so good. So sometimes you have to do all the above.
Yeah, and I have a feeling that is what we're going to end up doing with this lady. I had a question and I just lost it because I'm thinking about 10 different things right now. Let's bring this to a close, and I do have one more question for you, and we'll use that as our ender. And this is a question that I seem to ask you about every couple of years, and that is in cases where we're concerned about chronic infections. And I know that you state specifically, for example, with array 12, these are not tests for acute infections. most of the clients that we deal with in functional medicine circles are dealing with chronic health issues. So the Epstein-Barr infection, for example, is not something that picked up 3 weeks ago. It's something that they've carried perhaps for decades. Talk to me about the whole, how do we identify an active chronic virus, something that it is of clinical concern? And you and I have talked about a paradigm where we look at IgG antibodies that are more than 4 times the reference range. I want to check and make sure that that's still a good metric. I also wonder where that came from. Like, is that something that you learned from someone else? Is that something that you formulated just based on the thousands of different lab tests that you've run over the years? Where does that come from, and how can we employ this clinically?
First of all, let's establish that if IgM is elevated,
yes,
for HHV6, for EBV, that is clear evidence that the patient is having ongoing chronic viral infection. If early antigen D for Epstein-Barr virus is elevated, that shows reactivation of the viruses, meaning the immune system of the patient cannot control the EBV inside the B cells, and they are, they started become activated and dividing and probably causing lots of problem for the immune system. Now, IgG depends on reference ranges. In the case of HHV6, because I developed the reference ranges myself, and when I run, let's say once a week, I run 100 tests. If only 10 or 15 of those IgG are highly elevated, IgM is normal, I think there is some value for those elevated IgGs against HHV6.
Right.
So I will take that seriously. In the case of Epstein-Barr virus, unfortunately, the companies who are selling us the kits, they developed their reference ranges. Example that when I sent my HHV6 to LabCorp, in 96% of the cases, IgG turns positive because that's how their system. It's like VCA IgG. I think I have seen VCA IgG positive in probably 98% of the cases.
I see it all the time.
Okay. But unfortunately, we don't have the luxury of, if I wish that we could have a reference range for IgG that could differentiate between chronic versus non-chronic, would have been very helpful. The 4.0, 4 or higher, is based on my personal experience.
Okay.
Like the one I do for HHV6, but I have my own reference ranges. And I watch throughout the years that for thousands of samples I have seen that IgG elevation in about 10 or 15% of the cases, that should be significant. In fact, some companies selling kits for HSV 1 and 2, and they say if IgG is elevated, it is indication of ongoing infection.
And it's like anything above the lab range, or some kind of a multiple above the lab range.
Yeah, they are giving you the ranges.
They are, yeah.
Because in the case of the kit for HSV 1 and 2, also we find not more than 20% positivity.
So you're making me come up with more questions. For example, like let's say somebody has let's use HHV6. They have an IgG elevation that is maybe 2.5 times the reference range, right? So it doesn't meet that 4x standard that we're talking about. Yet we do a lymphocyte map and we find that they're Th1 dominant, not because they have an increased Th1 system, but because they have a decreased Th2 system. So it's a relative Th1 dominance. Could we theorize at that point, or maybe they have a decreased B cell population, Could we theorize that maybe that HHV6 IgG of 2.5 is clinically relevant because we think that their antibody production capacity is somehow compromised?
I think in the case of HHV6, yes, because I don't find many individuals twice or 3 times higher than reference ranges for IgG antibodies. As I said, we find that in about 10 to 15% of the cases.
Wow.
In about 1 to 5%, we find it very high. Like if it's normal, is 24, 25, 100, 120, 108,
yeah,
or 96. Those are very high numbers.
Yeah.
So if you find those numbers are very significant, very, very high, I think there is something into that. We cannot say everything IgGs indicate past viral infection, and IgM is only indication of ongoing viral infection. I think this is a great achievement between you and I today, that we agree that some IgGs have clinical significance.
Yes, absolutely. For example, yeah, and there's another clinical scenario that I come across that in my earlier years in learning immunology, most of which came from you. I started to look differently at a client that had, for example, a single latent infection that maybe I thought was an active issue. Again, let's call it Epstein-Barr, doesn't matter. Versus a client who, maybe we run multiple viruses, maybe we run an array 12 and they have multiple things active at the same time. I look at those two scenarios completely differently, because the scenario clinically where someone has multiple positive chronic infections, I look at that more of an issue with immune incompetence than I'm not really thinking, gosh, this person's got a pathogen load and I have to fix all the viruses. I'm thinking they have immune dysregulation and I need to fix that. That's the core issue. That's why they have so many that are active at the same time. Would you agree or disagree?
Yes, first of all, you and I, we have publication together in autoimmunity reviews. We looked at 750 cases of patients who we did testing for multiple viruses, and we found a significant percentage, about let's say 10%, who made antibodies simultaneously against HSV1 and 2, CMV, EBV, HHV6, and Borrelia burgdorferi. Measles, IgM.
Really?
Positive. Yeah. Measles, IgM. So can we say the patient is really having a problem with all these viruses and all these pathogens at the same time? I don't think so.
So you're thinking that's more an issue of cross-reactivity and false positives?
Cross-reactivity, polyreactivity, and immune function disorder as well.
How often are labs testing?
Case, I would look at, mainly our conclusion was HHV6 was so high for IgM that IgM cross-reacted with all the above, and therefore we should focus on treating HHV6. And then the immune system of the patient, as you said,
right?
Then I'm sure you are going to have good results with that. Otherwise, this patient is going from a doctor to another doctor without getting any answers, and eventually will end up with severe autoimmune disease.
Right. So can we translate that into some kind of a clinical model where, and I'm just thinking off the top of my head based on what you just shared, could we say that with a polyreactive viral test, for example, any IgM elevation is more important than any IgG elevation?
Yes.
And can we say also that if I have 3 or 4 IgG elevations, that the one that's numerically the highest as a quantum of the reference range is perhaps the main issue? Would that be a relevant question?
Yes, it is a very relevant question. We have seen that more often with IgM.
Mm.
I have seen that with IgG, 2 or 3 viruses simultaneously as well. Yes, your question is very well taken. We have to look at all the results and interpret them carefully. But Steve, one problem I have is this, that how many laboratories have this capacity to explain exactly what we discussed right now?
Yeah.
I will tell you, you have problem with measles, with herpes, with cytomegalovirus, with this and that, and go and be treated for all these pathogens at the same time. This is not helping the patient.
Right.
In that particular case, we are going to damage that patient rather than helping the patient.
Yeah.
But that's why you have to use a laboratory which have the experts who can explain the test results.
Yes, and hopefully
do not
marry
go
that.
after the cheap laboratories.
Yeah, that's right. You're not gonna find it there. But also coupling that with as we talked about earlier, having that fundamental understanding of immunology and how central that is to health and wellness. And just to bring this full circle, and we'll close, and I'll let you go off for the rest of your day. And your mentor back in the 1960s, who said that the future of medicine is immunology. I mean, how prophetic was that?
Incredible.
Yeah, very much so.
I owe everything to him. I owe everything to him. Not only myself, whatever I did for the humanity, that I believe I touched. If I touch 5,000 practitioners, imagine indirectly,
yes,
I touched how many patients?
Yeah.
So well, I appreciate all the help he gave to me. And that's more of a one-way street coming from you to me, because you have over the years been you've been a mentor to me. You've become a colleague and a friend, and you have had an irreversible impact on my thought process, which ultimately translates into me helping people who have not been able to find help in other places. And so I want to give you my heartfelt thanks as I thank you for your time. And I hope we can do this again. I mean, I could keep going. Steve,
but
this holiday, your statement means a lot to me. And I wish you happy holidays. Have a healthy year. Actually have, many healthy years.
Yes, many.
And yes, I'll make myself available to you anytime.
Thank you. And happy Hanukkah, Ari.
Thank
happy
you so
Hanukkah.
much. Thank you.